Hi guys, today we're going to talk about chapter 57, which is the umbilical cord. So we're going in a little bit more detail about that today. So a little bit about the how the umbilical cord develops. It really forms around during the first 5 weeks of gestation, and it's from the fusion of the yolk sac and the allantoke ducts. And the outpatching from the urinary bladder forms the uricus and it projects into the connecting stalk to form the allantosis. It's so important because it's basically the bridge of the life source between the baby and the placenta. So the baby can't survive without the umbilical cord. The vessels become the umbilical vessels, and the cord acquires epithelial lining as a result. The enlargement of the amniotic cavity and the envelope of the cord by the amniotic membrane. So it usually what I want you to get out of that is that the cord develops very, very early, about 5 weeks gestation. So I've talked about this a little bit before, but around like 7 to 10 weeks, when the baby's in their first trimester, the intestines grow faster than the abdomen. So what ends up happening as the abdomen expands, the intestines herniate out, and this is a normal thing. It's called midgut herniation, and it usually is between 7 and 10 weeks of gestation. And in a normal pregnancy, the bowel goes back into the fetus around 10 weeks. So this is like an image of it. Here's a cute little baby here, and the arrow is pointing towards just that mass there is actually the bowel. And it's just a normal thing that happens around you know, 7 to 10 weeks. This is a little bit about the umbilical cord. And you can see that all the vessels that are very important through the myometrium through the placenta into the cord. The cord is covered by amniotic membrane, and it includes two umbilical arteries and one umbilical vein. And I want you to know that. That's very important. It's surrounded by a substance called Wharton's jelly. That's another thing that I want you to know. And Wharton's jelly is like a connective tissue that varies in size. But the Wharton's jelly helps aid in the cord not getting um, it kind of is slippery, so the cord doesn't knot up as much with the Wharton's jelly. It kind of protects the cord. The diameter of the cord it measures 1 to 2 centimeters, and the normal length is 40 to 60 centimeters. These are two things that you'll need to know. And it's difficult to assess the length with ultrasound, basically because it is coiled. It is in a normal cord. It's coiled. It's all over the place. Um, it just is very difficult to assess. The umbilical arteries arise from the fetal internal iliac arteries, and they course along the fetal bladder, and they exit the umbilicus to form part of the cord. Now, the umbilical arteries actually are carrying the non-oxygenated blood back to the placenta, which is different than what we're used to thinking arteries and veins. And then the umbilical arteries branch along the chorionic plate of the placenta. The umbilical vein is formed by the confluence of the chorionic veins of the placenta, and the primary purpose is to transport oxygenated blood back to the fetus. So it's a little bit different, but the umbilical vein is carrying the oxygenated blood to the fetus. The umbilical arteries are carrying the non oxygenated blood away from the fetus to the placenta. The umbilical vein enters at the umbilicus and joins the left portal vein, courses through the liver. The intra-abdominal portions of the umbilical vessels degenerate after birth. Um, a couple of veins that are um, in us as fetuses, they close up and become like more ligaments after we are breathing on our own when we are born. The arteries become lateral ligaments of the bladder, and the vein becomes the round ligament of the liver. So that's pretty interesting. The normal insertion of the umbilical cord into the fetal abdomen in the late first trimester is like right here. And we always want to evaluate the cord insertion into the baby. And we want to see it in the center. We don't want to see, which we'll talk about in just a little bit, any kind of outpouchings in the later first trimester. And then we also want to put blood flow or color Doppler on the cord to demonstrate blood flow and to see the two umbilical arteries coursing along the fetal bladder. This is Morton's jelly, and sometimes you'll see like thickness around the cord. And basically, most of the time, what that is just the Morton's jelly. This is what a cord looks like. It's really a beautiful thing. This is a great image, 3D color Doppler image of the cord. And you can see that it's coiled, and that's normal. You want to see it coiled. When you're identifying, because one of the things that you want to look for, especially in your anatomy scans, when you're making sure everything looks good, is a 3-vessel cord. And there's really 2 ways that you can do that. I always will teach you guys at 20 weeks to look at the cord going into the fetus and then watching the 2 umbilical arteries split in the bladder. If you have difficulty due to fetal lie doing that, the other thing that you can do is do a cross section of the 3-vessel cord here, and you will see this 2 umbilical arteries in the big vein. It looks almost like a Mickey Mouse, and visualizing that is also a way that you can tell that it's a 3-vessel cord. Here's another couple images of the cord. And again, you guys should be experts at the blood flow from the placenta through the baby and back. But again, this is just showing the interconnectedness of the placenta to the baby. Now, the ductus venosus appears as a thin intrahepatic channel with echogenic walls. And what I want you to know about the ductus venosus is it shunts blood from the umbilical vein, from the liver to the heart. So the baby doesn't need tons of blood going to the liver. It needs some, but it really does need more going to the heart. So ductus venosus's job is to get that blood and to take it into the inferior vena cava so that not all the blood goes into the liver. And it lies in the groove between the left lobe and the caudate lobe. And it's patent until in fetal life until shortly after birth and transforms into the ligament venosum. Where we scan in maternal fetal medicine, we look at the ductus venosus to tell, you can tell if there's a cardiac failure or not from the Doppler waveform. So we do look at the ductus venosus quite a bit. The umbilical arteries are well imaged within the color flow Doppler. And again, it's another thing that I always want you to evaluate is seeing those arteries course through the fetus and kind of split along the bladder. And this is what I was talking about with the umbilical arteries coming across. The black hole right there is the fetal bladder, which we'll talk about more later in the bladder chapter. But this is a great way. This is like a transverse picture of the baby and looking at the booty. And we will put color flow going into the cord. And then you will see in a normal pregnancy 2 arteries splaying across the bladder there. And that's a great way to show that the baby has a 3-vessel cord. Now, I think it's interesting that the umbilical cord is the same length as the crown rump length in the first trimester. And again, a normal length of a cord is 40 to 60 centimeters. But again, that's difficult to assess really on sonography. Here's another image of it. So a short umbilical cord is less than 35 centimeters, and it's associated with different things. Oligohydramnios, which is not very much fluid, less than 5 centimeters of fluid, um, restricted space, and multiple gestations, intrinsic fetal anomaly, tethering of the fetus by amniotic band, inadequate fetal descent, cord compression, and fetal distress. The coiling of the umbilical cord is normal, and I want you to know that, and that's related to fetal activity. And the normal cord may coil as many as 40 times. It's usually to the left and near the fetal insertion of the site. It's helical twisting of the cord, easily determined by gross pathological inspection. So you should see cord coiling. It's really easy to see. If you don't see it, it's more like a straight cord, and that could be associated with trisomies or like anomaly or just lack of fetal movement, basically. So this is a left helix of a two vessel cord. Look at it just going. And that's what they look like, and that's normal. So this baby has a lot of stuff going on, but the absence of cord twisting is an indirect sign of decreased fetal movement. So if you see a cord and it just looks straight and you're not seeing that coiling, that's actually something that could be abnormal. So other obstetric problems seen with the short cord are preterm delivery, decreased heart rate during delivery, meconium staining secondary to fetal distress, and fetal anomalies. If the cord completely atretic, fetus attached directly to the placenta at the umbilicus, and the omphalocele is always present. So um, I haven't seen that very much, but if there isn't a cord, the baby is always just connected to the placenta. There seems to be a lot of other things going on when that happens with the fetus. It's not just a single anomaly, because the baby did not develop correctly because it didn't have the space to move around. So those are pretty sad um, things. Now, I've only seen that 2 times. I've been doing this for 15 years. So it doesn't happen very often. Most of the time, they just have a nice, beautiful cord. Now, long umbilical cord measures greater than 80 centimeters, and it may be associated with or predisposed to polyhydramnios, nuchal cord. Nuchal cord means wrapped around the neck. True cord knots, umbilical cord compression, cord presentation, prolapse of cord, and umbilical cord structure of torsion resulting from excessive fetal motion. Diameter of the cord measures from 2.6 to 6 centimeters, and variations in the cord diameter are attributed to diffuse accumulation of Wharton's jelly. Is associated with maternal diabetes, edema, secondary to fetal hydrops, RH incompatibility, and fetal demise. Cystic masses in the cord usually are pretty easy to see. They're generally small, but because of how the cord is, it's just very visible to see when there's a cyst on it. And they're usually near the fetal end of the cord. They resolve most of the time during the second trimester. And the cysts that persist beyond the first trimester are usually associated with other fetal anomalies and aneuploidy. Now, I have seen a couple of babies that have had quite a few cysts on their cord, and they end up having fetal demise. There's multiple different anterior abdominal wall defects that are associated with the cord. Now, we have an anterior abdominal wall chapter, which we'll go over some of these again, but just for you to be familiar with some of these things, I wanted to go over these with you. And those are omphalocele, gastroschisis, umbilical herniation, an aneurysm of the cord, varix of the cord, and teratoma of the umbilical cord. You can also have a hematoma of the cord, true knots of the cord, angioma of the cord, and thrombosis of the cord, secondary to compression or kinky. Now, I was talking to my coworker, and she actually has had 2 thrombose cords in the last couple of months, which is really interesting because you don't see it very often. And she sent me some pictures, and I'll put those up on your module for you to look at. Um, I asked her though, because of how the cord, how long it is, if it was easy to pick out the thrombus, because it was just in a certain area of the cord, and as we have learned, that cord is 40 to 60 centimeters long. So it's a lot to evaluate. And most of the time you don't end up evaluating it, but she said that it kind of just stuck out to her like a sore thumb, because in your eye you're trained to see like a normal cord. If you've done this so many times, you know what a normal cord looks like. And she was just scanning through, and it just, something looked abnormal. And when she put um the color Doppler on, it definitely looked like a clot, just like a clot that you would see in a vein. um in a lake. And so she took some images, told the doctor, and they ended up delivering both those babies within the week. And the doctor did confirm that they were blood clots within the cord. So um, she's awesome. And it makes you kind of nervous because you never want to miss something like that. But I think that as a sonographer, you get so, your eye just becomes such a trained eye, that you just are able to pick abnormal things out before you even really know that they're actually abnormal. So I'll put those on your module so you can look at those. So an omphalocele occurs in 1 in 5,000 births. It's a result from the failure of intestine to return to the abdomen, remember, in the first trimester. The hernia may consist of a single loop of bowel or may contain most intestines. And the covering for the herniac sac is the epithelial cord. So one thing I want you to know about an omphalocele is that it always has a membrane covering it. So this is a transverse image of the abdomen of the baby. And then you can see the figure 8. The omphalocele almost looks like a figure 8 because there's an outpouching of liver, seems to always be in there, bowel, but you can see that there's a membrane that is surrounding that area that is outpouched, and then the cord goes through this area. A lot of the times with omphalocele, they're most of the time associated with a congenital anomaly, such, or an aneuploidy, such as like trisomy 18. But I have seen in the last year a couple of omphalocele that it was just an isolated event, and the baby, how overall, did good. But it seems like omphalocele are associated with other things, heart defects, kidney issues. Um, so that's an omphalocele. Here's another image of it from a sagittal view. So you can see the baby, the profile, the heart right here, the spine, and then you can see a large outpouching of her liver and bowel and gut there. Here's an image of a baby with it afterwards. Now they do repair this right after birth. A lot of the babies do okay, especially if this is an isolated finding. Sometimes they have issues with bowel, volvulus, ileus, like some issues with twisting the bowel later on. Gastroschisis is different because it's right para-umbilical defect involving all layers of the abdominal wall. It's usually 2 to 4 centimeters. It's mostly small bowel that eviscerates through. There's no membrane, no membrane. So that's the difference. One of the differences between gastroschisis and an omphalocele. It directly exposed to amniotic fluid. And other organs may eviscerate, but I see most of the time with gastroschisis, it's small bowel. Here's one image of it, and it's always to like the right of the cord. So the cord goes in, and then the um like outpouching of the bowel is adjacent to it or next to it. Here's another image of it. There's no membrane separating it, and it just looks like bulging bowel. Here is a good picture that you can with a baby afterwards, so you can see the difference. Like it's just bowel that's eviscerated versus then omphalocele was like more liver, like outpouchings like that. I'm partial to gastroschisis because my husband was born with gastroschisis, and he's done really well. He's had a couple of bowel issues with when they in 1982 when this happened. It was scared him to death, at Wesley. And so he was in the NICU for like 3 or 4 months. That doesn't happen as much anymore because we most of the time, I mean, they still are in the NICU for a while, but they tend to do better because, medical advances. But he did really well until in his 20s. It seemed like he had a um, twisting of his bowel, and they had to go back in and reroute his bowel. And I think sometimes that happens with gastroschisis because of some adhesions, surgical adhesions and stuff. But overall, the babies do pretty well. They're not, most of the time, it's not associated with any kind of aneuploidy or trisomy. So omphalocele seem to have more of that associated with something else. Well, gastroschisis seems to me more of an isolated event. Umbilical herniation is a little bit different because it occurs when the intestines return normally to the abdominal cavity and then herniate either prenatally or postnatally through an adequately closed umbilicus. And this is one image of that. So it's not as severe as the other ones that we've seen. Mesenteric cyst is a cystic lesion of the cord caused by persistence or dilatation of the omphallomesenteric duct, and it's lined by epithelium of the GI organ. Again, it usually is a cyst just right next to the insertion of the cord. It's closer to the fetal cord insertion. Like I said, it varies in size up to 6 centimeters and it affects females over males. A hemangioma of the cord. It's very rare. And so I wouldn't worry too much about it, just what it is. It's what I really want you to know is more of the hematoma. Its trauma to the umbilical vessels may cause extravasation of blood into the Wharton's jelly. It's usually near the fetal insertion of the cord, umbilical vein most frequently involved. So basically like a blood clot in the vein. If the blood clot is new, mass is hyperechoic on ultrasound. If clot is old, it's more hypoechoic and septated. And its complications is reported as high as almost 50% with fetal mortality. There's a hematoma. That's a large hematoma. Thrombosis of the cord is the occlusion of one or more of the cord vessels. Primarily occurs in the umbilical vein. Incidence is higher in infants of diabetic mothers. The primary or secondary torsion, knotting, looping, compressions, or hematoma. This is what my coworker has found. Other maternal factors are phlebitis or arteriitis. The prognosis is poor with umbilical vein thrombosis. If they're not delivered early, both those babies survived because my awesome coworker. True knots of the cord have been associated with long cords, polyhydramnios, intrauterine growth restriction, and monoamniotic twins, where there's no sac separating the twins, so they're just all up in each other's business. Knots may be single or multiple, increased incidence of congenital anomalies. And this is what a knot looks like. Isn't that crazy? On ultrasound, what you're going to see is just a bunch of cord that is just all knotted together, basically. They may be formed when the loop of cord slipped over the infant's head or shoulders during delivery. And usually the umbilical vessels are protected by the Wharton's jelly and not constricted enough to cause fetal anoxia. So good job, Wharton's jelly. False knots are seen when the blood vessels are longer than the cord. That's close to know with some false knot cords. Nuchal cord is the most common cord entanglement in the fetus. Multiple coils around the fetal neck have been reported. Now, I'm sure that you have heard of a baby that's been delivered, or you know someone that had the cord has the around the baby's neck like multiple times, and it's very common. Most of the time, the babies do fine. If you see that on ultrasound, most of the time we don't really do too much about it because the baby, they won't deliver a baby over a nuchal cord unless if the biophysical or the baby doesn't seem like it's in fetal distress. But it is kind of scary to see the cord around the neck multiple times. Okay, now you guys know a little bit about different abnormalities in the umbilical cord insertion. We just kind of went over this, but the battledore placenta or marginal cord insertion is where the cord goes into the edge of the placenta instead of the middle. You know that. And this is significant when the cord is towards the internal os, and that might be because of the blood vessels that would be around the cervix. A velamentous cord insertion is when the cord goes into the membranes instead of the placenta first. And this is an increased risk of thrombosis, cord rupture during delivery, and vasoprevia. Remember vasoprevia. A velamentous cord insertion is associated with a higher risk of low birth weight, small for gestation, preterm delivery, low APGAR scores, and abnormal intrapartum fetal heart rate pattern. Now we know about vasoprevia is when the vessels of the membrane course along the cervix. Prolapse of the cord occurs when cord lies below presenting part. May exist whenever presenting part does not fit closely and fails to fill pelvic inlet. Further risk incurred if membranes rupture early. So the compression of the cord reduces or cuts off blood supply to the fetus and may result in fetal demise. And a normal fetal presentation occurs in half of the prolapse cord cases. So we don't want that cord to come first. Slightly higher risk when fetus is in transverse or breech presentation. The presence of the umbilical cord vessels crossing the internal os is vasoprevia. And you guys know that because we kind of went over that earlier. Now, the mortality rate is going to be high for this if it's during the vaginal delivery. If we didn't know that it was a vasoprevia. That's what it looks like. Conditions predisposing to cord presentation and prolapse are as follows. Abnormal fetal presentation. We want the baby to be head down vertex. During delivery, if they're in a different position, that could cause prolapse. If the fetus isn't engaged into the cervix, if they have a long umbilical cord, if the mom has an abnormal bony pelvic inlet, if there's fibroids, if there's a lot of fluid, if there's a vasoprevia, velamentous cord insertion, marginal cord insertion with low-lying placenta, and incompetent cervix with PPROM. So prematurity, multiple pregnancies, and obstetric procedures such as artificial rupture of membranes, disengaging head, flexion of extended head, version extraction, all can cause cord prolapse. So a single umbilical artery, we've talked about 3-vessel cord a lot, but what if the baby has a 2-vessel cord? Well, it happens quite a bit. I'm seeing a lot of 2-vessel cords. Occurs in about, I feel like more than 2% of single limb births, but maybe it's because we scan so many babies, or 3.5 of twin pregnancies, and they're more frequent in miscarriages and autopsy series. So the single umbilical artery has been associated with congenital anomalies in 20 to 50%. So if you see a 2-vessel cord, there is a good chance that there could be something else going on. I see that sometimes heart defects are associated with two vessel cords, um, kidney issues associated with two vessel cords. There's an increased rate for perinatal mortality and increased incidence of chromosomal abnormalities. So this is one vein, one artery. So you can look at it and diagnosis this way. You can also look at it coursing along the bladder, and you'll just see one umbilical artery instead of two. This is just the cord Doppler for that. Infants with a single umbilical artery are associated with anomalies in these issues. So musculoskeletal, genitourinary, cardiovascular, GI, and central nervous system. A varix of the cord is a focal dilation of the umbilical vessels affecting the umbilical artery and vein. So right when the umbilical artery and vein go into, or the umbilical vein goes into the baby, there's kind of a dilatation of the umbilical vein near the extrahepatic in location. And let me see. On sonography appears as a dilated intra-abdominal extrahepatic portion of the umbilical vein. So the vein is just really dilated. Prognosis is usually a normal outcome, but it kind of looks like this. It's going to be um, a larger vessel. And that's it for this chapter. Thanks.